All right, we're going to go ahead and get started. Hello, everyone, and welcome to another session of the Virtual Global Spine Conference. We are excited to have colleagues here with us today, joining us for really a special session here with one of our co-hosts, Dr. Dahdaleh. Dr. Dahdaleh needs no introduction. He is part of the team here, part of the home team of Virtual Spine. And he is obviously an exceptional surgeon in all ways, but he seems to certainly have a specific expertise with the cervical spine and with the CVJ, with the craniovertebral junction, and we always benefit from his cases. With us as well as Dr. Mamagani, one of our co-hosts, as well as several colleagues will be joining us. I want to say that just a special thank you to everybody who's with us today and everybody who will be seeing this later on today. Many of us just came back from a very successful meeting, national conference for neurosurgeons in Washington, D.C. And I think Dr. Dahdaleh will share that as well. But you know, so many of us had so many people come to us, at least a dozen or so folks that we know, and some of them we really don't know, just thanking everybody for the efforts and for this initiative. And it really meant a lot. It meant a lot to all of us, because we know that there's a lot of work that goes into this. We're trying to stay on a routine every week. You know, obviously very busy folks here taking time from their schedule to do this for everybody. So we really appreciate it. We don't take it for granted, and we appreciate the opportunity both to teach, but also to serve the general spine audience, if you will, and we're absolutely elated to have all of that great news coming out of that conference. So without further ado, Dr. Dahdaleh, welcome. It was great to see you a few days ago, and thank you for being here and sharing your expertise.
Thank you so much, Dr. Baj. It's always a pleasure to present at this platform, who's stood the test of time now. We're almost in the middle of our third year with these online seminars. Today, it's one of my residents, one of my supreme residents, Dr. Rebecca Deuce. She's going to be tuning in with us today and during this presentation. And the reason I chose this talk, management of cervical spondylotic myelopathy, or evidence-based management of cervical spondylotic myelopathy, also known as degenerative cervical myelopathy. The reason is we had a very luncheon year to year at the Congress of Neurological Surgeons. We have a luncheon seminar about this topic, anterior versus posterior surgery for cervical CSM, and it's usually sells out, and it's very widely attended. We always include many faculty who are really pioneers in the field of cervical spine, and one of them is Dr. Gogawala, who's a trialist. He contributes with clinical trials. He has the SLIP study for spondylolisthesis, operative versus fusion versus decompressions, and he has a more recent study that was published about anterior versus posterior cervical spondylotic myelopathy, a randomized trial. So we'll go over that. So it's a very popular topic. A lot of our patients that we see in clinic suffer from cervical myelopathy. I see more cervical myelopathy patients that I see radiculopathy patients, because a lot of the radicular symptoms improve with non-surgical treatments, while cervical myelopathy symptoms usually it progresses with time, and oftentimes patients would need surgery. So this is my conflict, and it's always good to start with a case study. I'll present the case, then we'll look at the evidence, and we'll see what the evidence says. So this is a 79-year-old woman with rheumatoid arthritis on prednisone and also on Actemra. She has a history of also pneumonia, CMV, sores in her tongue because of her immunosuppressant medications and biologics. She presented with a 2-month history of shoulder pain and weakness, rapidly progressing weakness in the upper and lower extremities. She complained of gait dystaxia, recurrent falls, actually progressively presenting with relatively fast progressive symptoms over 2 months. So on exam, her upper extremity motor strength was, she was weak, noted to be weak in her hand intrinsics, 4 out of 5. On exam, she was full strength to the examiner. However, she definitely had subjective weakness in her lower extremities. and she had brisk reflexes congruent with an upper motor neuron pathology, upper extremity brisk reflexes, as well as positive Hoffman's. So this is her scan. You look at this, you can see here, her BMI was low, but you can see a buffalo hump here because of the chronic steroids. Now, and this shows circumferential stenosis, mainly focused at these two levels, 5, 6, and 6, 7, both anterior and dorsal compression. So that's a common pathology that we see in clinic, and we tailor our treatments towards not only the pathology but also comorbidities. So I'm just in general, I'm really interested to see the audience. What would they do for this patient? How would they approach this? She's 79. She probably has osteoporosis. She's on chronic steroids, and she has cervical myelopathy with circumferential stenosis. What would you guys do? What would you do, Dr. Malgani?
Yeah, hello, Nader. Thank you very much. This is quite common. May I ask you, did internal medicine call you for a consultation because she was in internal medicine and then she complained of the symptoms, or did the family doctor, the general practitioner, send the patient to you? Because
yes,
many
that's
of
exactly
these
what
patients,
happened. She was, she has comorbidities. She's seeing her primary care physician, and but that was her main complaint: weakness in the arms and the legs. So that's why they saw her, and they worked her up with an MR. And then once they found the results and look at the study, they notified me and wanted me to see her sooner rather than later, given the
hey,
findings.
but it's a big applause from me to the internal medicine that they thought about cervical myelopathy. This is not something the internal medicine is thinking about. They often say, oh, it's a pneumonia, it's a rheumatoid arthritis, steroids, so fatigue and weakness. And so my job primary is to influence internal medicine and to make the awareness of myelopathy in our society. And so a big applause to internal medicine that they have run this MRI. So I asked the checkbox, and the first was an anterior approach, like corpectomy, and the level was 5, 6, maybe it's 6. I think it is a good approach to look where is the issue coming from. Is this anterior compression? It's a posterior compression. And I think we see here now the level mainly is 6, 7. We see a slight slip on the MRI. Maybe X-ray will relieve more than this slip. We can see slight edema in the myelin, not only in the sac T2 on the left side, but also in the axial T2 on the right side. We see an edema in the myelin in the cord. So it's a classic sign of cervical stenosis with a myelopathy, DCM. And also we have the command going from the back, short decompression infusion, because we see the flavum is in the posterior part, there's a compression as well. And we know that laminectomy is a really powerful tool. After laminectomy, there's CSF around the myelin everywhere. Maybe a fusion, Dr. Shariva recommended, while Dr. Adeshiri said corpectomy anterior approach. I think you have to decide. You have to talk to the patient.
Exactly. I mean, with these cases, it's either anterior or posterior or circumferential fusion. Obviously, laminectomy, it's fallen out of favor over time, especially multi-level laminectomy as an option because of the higher incidence of post-laminectomy kyphosis and worse outcomes. Now, cervical myelopathy, obviously, it's the most common cause of spinal cord dysfunction in adults worldwide. So that's why more and more PCPs are becoming more aware of it, because it's one of the most common causes of gait dystaxia, in addition to vitamin B12 deficiency. People misdiagnose it sometimes because there's lack of neck pain. It's easy to diagnose cervical radiculopathy because it's painful. In fact, patients go to the ED right away. However, sometimes patients go undiagnosed for months, maybe years, because of lack of pain. What brings patients to medical attention is no more pain than neurological deficit. So there are wide spectrum of symptoms: upper extremity weakness, lower extremity weakness, gait dystaxia, loss of hand intrinsics, and the severity of symptoms is classified according to the mostly used classification system and severity scoring system. It's the MGOA. So mild patients with mild cervical myelopathy that are defined by an MGOA of 15 through 17. Moderate is 12 through 14, and severe is 11 or less. And we have also a patient population who are non-myelopathic, but there's evidence of spinal cord compression. We'll look over the evidence on how we approach these patients. Now, this is the MGOA. It's 4 categories, looking at motor dysfunction of the upper extremities, 0 through 5, motor dysfunction in the lower extremities, 0 through 7, sensations, complete to no loss of sensations, 0 to 3, and sphincter dysfunction, inability to micturate voluntarily versus normal micturition. The higher the score, the better the patient neurologically. So basically, we'll go over when to treat these patients. So we'll go over the recommendations of guideline recommendations, and then what to do, anterior versus posterior, based on the current evidence. So when to treat. So the most recent guidelines were published by Fehlings and colleagues in 2017. So it's been about 6 years. And you know, this group of people will look at all the publications and will classify the evidence based on the quality of the evidence. Randomized trials would definitely drive the level 1 quality, and then they will give a recommendation: weak versus strong versus moderate. So when they looked at patients with severe DCM or CSM, these are described with an MGOA of less than 11 or less. Should operative management be used to treat these patients with severe CSM? The recommendation was, yes, we should. The level of evidence or quality of evidence is moderate because it lacks randomized study. No one's going to randomize patients with severe myelopathy, conservative treatment versus surgery. Probably unethical. So what we have, we rely on the evidence of retrospective studies, but the recommendation is strong. You must treat these patients surgically. No one's going to doubt that. The second group of patients are patients with moderate CSM, MGOA 12 through 14. Again, the panel or the guidelines is for surgical intervention with moderate CSM. Same thing, quality of evidence is moderate. However, the strength of recommendation is strong. Now, patients with mild CSM, 15 through 17, here the quality of evidence is low and the recommendation is weak towards surgical intervention. So they would say you can either offer patient surgery versus supervised trial of structural rehabilitation with mild CSM. So I have a lot of patients in my clinic with mild CSM. However, they have some comorbidities, or some of them are not really interested in surgical intervention. We educate them well about, not to be engaged in high-risk activities, because if they suffer a significant accident, this may be an issue. However, I follow them, but I know they're reliable. I've also placed some patients on, or recommended some of them to go to, especially those who have gait dystaxia, isolated gait dystaxia, to pursue physical therapy and balance therapy. So the recommendation here, you can go either way with patients with mild CSM, either close follow-up / supervised trial of rehab versus surgical intervention. Again, the evidence is quality of evidence is low, strength of recommendation is weak. Now, patients with who do not have cord compression or severe stenosis, but have radiculopathy, they don't have myelopathy symptoms. So stenosis, central stenosis, severe stenosis, but no myelopathy. So they don't have brisk reflexes. They do not have gait dystaxia. They do not have the symptoms too: numbness in the hands, feet, and weakness, they have radicular symptoms. So the guidelines suggest offering either surgical intervention or non-operative treatment of closed serial follow-up and supervised trial of rehabilitation. Same applies to these groups. So patients with mild myelopathy versus patients with no myelopathy symptoms, however, radiculopathy, you can go both ways. Again, the quality of evidence is low, strength of recommendation is weak. Last but not least, those patients who come to your clinic who had an MR of the cervical spine for some reason, but are totally asymptomatic, no symptoms. So severe stenosis, no symptoms. And here, the guidelines suggest not offering patients prophylactic surgery, not offering patients prophylactic surgery. Quality of evidence, it's just expert opinion. So there's no evidence, it's expert opinion. And strength of recommendation weak. So if there's no, if there's no published literature, what do you resort to? There's no empiric evidence, you resort to rationalism. So expert opinion. So here, I agree with that. In a couple of instances, when there was really critical stenosis, I ended up operating on these patients. Very rarely you'll have that much compression with no symptoms, but I had a couple of instances where I did not follow the recommendations, and I did surgery prophylactically. But certainly, a prophylactic surgery is not recommended because the risk outweigh the benefits. You're just exposing patients to risks. Okay, so here we went over the guidelines, when to treat. Okay, so now the more exciting part of the talk is what to do, anterior, posterior, or both. And here, I'm gonna just go over the most recent evidence with the highest quality. I'm not gonna go over, anecdotal, small cohorts or retrospective studies or, here that databases of insurance companies and so forth. So we'll go over this study, which preceded the trial. This is it's a study that encompassed two cohorts of patients. One was the AO Cervical Spondylotic Myelopathy North America, CSM North America study, and the AO CSM International, CSMI. So these two cohorts of patients, these are prospective longitudinal studies looking at patients with cervical myelopathy and what they ended up undergoing, if it's anterior or posterior surgery. Most of the patients with anterior surgery underwent ACDF. Most of the patients with posterior surgery underwent posterior decompression and fusion. Very small number of patients underwent laminectomy only, and a small number underwent in the anterior group corpectomy. So when you're looking at this data, which is real life data, so you have this cohort of patients and they follow them, and they're not randomized, obviously. They just follow them and they see what happens to them, whether they undergo anterior surgery versus posterior, and they analyze specific outcomes. So you look at those cohorts. The anterior group comprised 255 patients, and the posterior group 180 patients. However, and you look at all these covariates, all these predictors, age, BMI, comorbidities, MRI findings, single level, multi-level, subluxation, ligamental level enlargement, you can see that there are certainly differences, significant differences of all these confounding variables. So these are all confounding variables that will impact outcomes, obviously, because, for instance, we tend to operate on patients posteriorly if they're older. Anterior patients are usually younger. Preoperative MGOA, they're a bit worse for the posterior patients. The prevalence of multi-level disease is higher in the posterior patients. Single-level disease obviously doesn't exist. So they're very different. So you can't compare them because all of these are confounding variables. So how do you adjust for that? Obviously, adjust for that with statistics. There's a methodology robustly used. It's the propensity score match analysis. So what you do is you match these patients, and you select the patients with similar characteristics. And what this helps with, it's a powerful statistical tool, actually as good as a randomized trial sometimes. It makes both cohorts similar and eliminates the any confounders. So now what this does, it drives down the number of patients. So now we have 80 and 80. However, all these covariates are similar. So now the average age is less than almost similar here, 59 and 58. Before it used to be much higher, 61. And it makes the patients more comparable. Now, so what it throws away, for instance, the average number of levels would be much higher in the posterior group than the anterior group. The average number of levels operated on would be less than the posterior group. So, but this is a way to make these groups comparable. So now you can compare them, and you can deduce more accurately conclusions. So looking at both groups post matching, you can see that the operative time is pretty similar. The outcomes, all of them are similar. There's no p-value that's statistically significant. So the NDI scores are similar. Recovery rate is similar. MJOA score after surgery improves similarly. And the SF-36 physical and mental components are similar. So both groups improve, and they improve to a certain extent with anterior surgery versus posterior surgery. But what this should tell you too is that probably the patient with a 5-level disease was excluded from this study, right, from the analysis, because they wouldn't have been matched. Here too, looking at the 30-day perioperative complication, we all know dysphagia is more prevalent with the anterior group, unheard of almost in the posterior group, and wound infections are higher in the posterior group because they're splitting the muscles. And then certainly the C5 palsy, you see that more in the posterior group. But that's a pretty low rate here, which is good, 3%. So the best way to answer a question, obviously, is with randomization. Why? Because randomization would take care of confounders just because of the randomization process. So this is a study, it's a multi-center study in the United States, included 15 centers, led by Dr. Zohar Gogawala, a trialist. The senior author is Ed Benzel from Cleveland Clinics. So they randomized patients 2 to 3, 2 into the anterior group, 3 into the posterior group, because they wanted to include patients who undergo laminoplasty in the study under the posterior group. So the inclusion criteria, so with any trial, you need to look carefully at the inclusion criteria and the exclusion criteria to see if the conclusions of the trial fits your specific patient. Because if your patient belongs in the exclusion criteria, then you won't be able to generalize the conclusions from the study to your patient. So they included patients 45 through 80 years old, patients with 2 or more of the following symptoms: clumsy hands, gait disturbance, hyperreflexia, Posner-Babinski, and then 2 or more levels of spinal cord compression, C3 to C7, that is confirmed on an MR or a CT scan. So they included these patients, and they excluded patients with C2 to C7 kyphosis greater than 5 degrees, segmental kyphotic deformity defined as more than 3 discs ossified extending dorsal to the C2, C7 dorsocaudal line, which is what they call is the effective lordosis line of for effective lordosis, significant OPLL, previous spinal surgery, and significant comorbidities, ASA over 4. Okay, so these patients were not included in the trial. So that's a typical patient that is included in the trial, and a patient with, that can go either ways. That means they achieve clinical equipoise. And I'll tell you how did they do that, how did they establish equipoise, which is important to establish in any trial. To establish equipoise because you want to serve patients well. You should truly believe that either approach is appropriate for the patient. Otherwise, it's not ethical. So you can see this is a patient typically close to the one that I presented. You can go either front or back, okay? And does not have good effective cervical lordosis, no instability. However, for instance, these patients, obviously, these are my patients, none of which would have been included in the trial. Okay, this is a patient with OPLL, exclude that. This is a patient who was 81 years old, the trial up to 78. This is a patient, the previous multiple surgeries. This is a patient of multiple surgeries and post-laminectomy kyphosis. This patient that I presented also would not be included in the trial. And that's also extensive OPLL here. That was not that won't be included. So I just want to tell you to re-emphasize that really, if you want to look at the conclusions from a trial, you want to ensure that your patients fit the inclusion criteria. So how did they establish equipoise? Pretty nice. So they have a panel of 15 surgeons who each will look at each radiograph and would decide if that patient is fits or can go either way in their opinion. And each of these experts would also include what would they do for the patient. Okay, what would they do for the patient? For instance, so one voted anterior corpectomy, for instance, for a certain pathology. One voted, 4 voted ACDF. 1 preferred the laminectomy infusion, and 6 preferred the laminoplasty. So you can see some distribution. Some will go anterior, some go posterior. So the result of this, all green, and a variety of approaches, you would randomize a patient like this. Now, if someone thinks that, let's say all of them, they think it's anterior, and even though they would think it can go both ways, that patient won't be randomized. So you take both into account. I'm not going to belabor this. So that's the, you included 468, and then some of them are excluded, and then you randomize. They ended up randomizing 163, 100 in the dorsal surgery, and 63 in the ventral surgery. So these are the baseline characteristics. Obviously, with the randomization process, all these should be the same. The randomization takes care of confounding variables. That's what's really nice about trials. Same age, distribution of sex, same ethnicity, which is excellent that they included that. Most of the time, this is not mentioned. And the number of levels and so forth, and the baseline scores also they're similar. So, and looking at the outcomes for the change in SF36 score, you can see the dorsal laminoplastic group up means improved, down means gotten worse. So most of the time, the laminoplasty, dorsal fusion, ventral fusion, they're all up. That means most of the patient improved on average. And you can see here, looking at them until the 2-year follow-up, there's no difference in outcome when you're looking at the SF36. Anterior and posterior surgeries are good surgeries. Patients improve, and they sustain, and that is sustained, and there's no difference between these two groups. Complications, similar to the prospective North America study that I just mentioned. The set of complications for ventral fusion versus dorsal fusion is predictable. Dysphagia is more prevalent in the ventral fusion group. There's dysphagia, DVTs. There's 1 DVT in the dorsal group. So there, more or less, there's no difference. But what stood really nicely, like what stood out in this study, when you sub-analyze the dorsal laminoplastic group, really they have the least complications amongst when compared to the dorsal fusion and the ventral fusion groups. This is also more of the same, but this is more granular analysis looking at dorsal laminoplasty and showing when you establish equipoise, the dorsal laminoplasty option is a great option. So you can see here the neck disability index is better than both the anterior and the posterior fusion groups. SF36 is pretty much the same, but there is some advantage. Some advantages to doing cervical laminoplasty. There's no doubts about that, and you can see that clearly. This is a secondary analysis looking at dorsal fusion, ventral fusion, and dorsal laminoplasty, and you can see here for the SF36 physical how much the dorsal laminoplastic groups improves. Okay. So when you establish clinical equipoise, dorsal laminoplasty actually stands out as superior than both groups, but that was not the primary outcome. That was the study that the study aimed to look at. The outcome was anterior versus posterior, not laminoplasty versus ventral fusion versus dorsal fusion. Same thing, return to work. The dorsal laminoplastic group performs the best at 1 year. And you can see here the two-year mean change from baseline in terms of the of outcomes. Euro Quality 5, it favors also the dorsal laminoplastic group. So now this is another study. It was a survey looking at what drives the decision making among surgeons going ventral versus dorsal, and the survey concluded that a large degree of anterior cord compression and cervical kyphosis surgeons would be influenced towards an anterior approach. Conversely, a high degree of posterior cord compression, congenital stenosis, multi-level stenosis, OPLL would definitely drive the surgeon towards the posterior approach. And also, as importantly, surgeon preferences influence with a type of training. Some people are more comfortable with anterior approaches. Some people are more comfortable with posterior approaches. Some people are really good in laminoplasties. So also your technique and your comfort influences the decision making. So how do I think about evidence-based medicine in my practice? Especially after the most recent clinical trial, if you establish clinical equipoise, probable laminoplasty is more superior than ACDF and PSF. And the candidate for laminoplasty is a patient with no neck pain, good cervical lordosis, and in my opinion, no radiculopathy. Some people do myeloradiculopathy, and they have them undergo laminoplasties, but my preference is no pain, just painless myelopathy. In cases where clinical equipoise is established, meaning, oh, I can do a dorsal decompression infusion or an ACDF or a laminoplasty. If you think that all these approaches are appropriate, then you'd go with a laminoplasty. If someone has neck pain or radic, I would prefer an ACDF versus a PSF. Now, if someone has multi-level cervical stenosis, 5 levels, and is older, certainly I would not do a 5-level ACDF. I would do a posterior decompression infusion. So that's how I use evidence-based medicine. So I said here, otherwise individualized treatments. Okay,
Nader,
any question here? Alfredo, good to see you. Good. Yeah, what do you say,
hey guys,
Alex?
how are you?
Good.
Nader, may I ask you a question?
Sure.
When did you learn ACDF in your career? When did you learn decompression and fusion from posterior? And when did you learn laminoplasty? Was it everything happening the same?
So yeah, great question.
Is there a difference?
Yeah, great question. So I learned ACDFs and posterior decompression infusions in my residency. Continued definitely through fellowship. I learned laminoplasty a little bit in fellowship. We didn't do too many. And now I did a couple or like a few as an attending, driven by the evidence, especially at Zohar Gogawala. I mean, the evidence is compelling. Like, you cannot ignore it. And when you speak with people who do laminoplasties, they love it. And patients like it. And my patients that had a laminoplasty, they're very happy. They are very happy. But it's not for every patient. You know, it's a neck pain, I won't do it. Kyphosis, certainly I won't. OPLL, I won't do it, although it was firstly used in patients with OPLL. But I think OPLL fusion should be part of the treatment of OPLL. Otherwise, it progresses, in my opinion. So yeah, I think my comfort levels with ACDF and posterior fusions is much more than a laminoplasty, but you can learn it, and you get better at it, and it certainly is superior in a patient who can undergo any of these 3 approaches. I think a laminoplasty, the evidence is very compelling. Can't ignore it. That for the right patient, a laminoplasty is a good operation. It is.
Yeah,
but I still do, by and large, ACDF, scorpectomy is PSF. Like, that's 95 plus of my patient population. That's what I do.
Yeah, this is something I wanted to highlight, because I'm an orthopedic surgeon. Although I've had a deep look into neurosurgery, I didn't learn laminoplasty in residency or later, and it's severely it is really hard to learn this later on when you manage an ACDF in a couple of minutes, 1 hour, 90 minutes. It's so easy. You're so comfortable with, and then evidence tells you, hello, laminoplasty superior. And then you have to leave something you're really good in, and you have to learn something new because you have this commitment to your patients, and evidence tells you this is better, this is superior to ACDF. So this is really, it's hard for me as an orthopedic surgeon, because I didn't do intradural tumor resections where I did laminoplasty for a different reason, for other reasons. The workhorse, the posterior fusion, I do for ang spondy fractures. So often in trauma, I don't need laminoplasty in trauma. So it's really hard. It's nice to hear from you that you didn't learn laminoplasty in residency. I'm glad.
It's not a common procedure, to be honest. Like, people, it's becoming more and more common over time. But again, it's for the right patient. It's for the right patient. Let's say there, in my opinion, let's say you look at like 100 patients with cervical myelopathy. I would think you will find five of them, in my opinion, that are good laminoplastic candidates, right? Like, so I learned it for those people, those 5 out of 5-10%. But I still.
And which technique of the 1,000 described techniques of laminoplasty did you pick up and you go for? This is my
the easiest, the
technique of
open door. You crack the bone on the right side and then open it on the left side, and then you put the plates. It's not a very difficult technique, but it's a technique. I think, amongst all these new, evolving techniques and the OLIFs and what have you, I didn't definitely learn all of them, but I think a laminoplasty, given the evidence, compelling evidence, is a good technique to keep in your armamentarium for the right patient.
Alfredo, may I ask you, in Argentina, what is most common in Argentina?
Well, I was lucky that laminoplasty is very popular here, so I learned that early in my residency. And it's as every technique, it's technique dependent. If you do a wrong laminoplasty, you're gonna have C5 palsy, you're gonna have post-op kyphosis, you're gonna have pain. But when you have the right technique and you follow the steps, it's pretty reproducible. And we take a lot of care about the pre-op X-rays for those cases. We look at T1 slope. If the patient have a high T1 slope, it's not a good idea to do laminoplasty. It will get to post-op kyphosis. Lower than 20 is the cutoff, more or less. And good lordosis, cervical lordosis, closely to even when it's straight spine, you can do laminoplasty. Even when the compression is anterior, you will see in the follow-up that the bone and the disc will remodel. With that, it's like when you do neurofibromatosis and you see that dural ectasia is the same phenomenon. So I'm a very laminoplasty guy.
Okay, thank you. And one last step to down under in Australia, Dr. Mike Selby, he's our orthopedic surgeon from Australia. Mike, are you there? I know you like laminoplasty as well. Let's unmute him.
Yeah, you gotta.
Just. I cannot unmute him.
Yeah, it's. I think Dr. Baj. Let's see.
Yeah, sorry, I can't unmute him. Sorry, Mike. I apologize. Nader.
I think is Ali still with us? He's the host. He can unmute.
Oh, we have to skip this. Sorry, Mike. We can't hear you. Nader, would you like to continue?
Sounds good. All right. So going back to our case, this lady 79, prednisone, because she has on prednisone for RA on a biologic, osteoporosis with myelopathy. So that's what she had, and this is the CAT scan. Okay, she has a little slip here, and these are the index levels. And you can see she has a little positive CSVA, not too bad. So what I end up doing, because patient's bone quality was suspect, I usually do more if someone has bad quality of bone. So I ended up doing a front-back corpectomy and posterior fusion. Did well after that. So you can get away with a corpectomy only. Probably you can get away with the posterior fusion. But I tend to do more for patients. You can see her T1 slope is a touch elevated. For patients with poor bone quality, and as Alfredo mentioned, a high T1 slope. So I want to give a 360. So this is a patient with who's 47, also severe progressive myelopathy, and that's his scan. What would you guys do?
CAT scan.
Would you order more imaging, or?
Yeah, CAT scan. It's probably an OPLL.
So this is an OPLL. Okay, so this is OPLL. So what would you guys do? What would you do, Alfredo, for this patient?
Posterior decompression and fusion. As you mentioned, OPLL in my hands is a fusion. 90% of the cases posterior fusion.
100%. I did that long time ago. I would do a posterior fusion every single time for this kind of patient, but at that time, I went anterior with a 2-level corpectomy, and certainly I was prepared for a CSF leak. It was not even it was you resect dura. You got to resect the dura because he had a. So this is the crescent sign. So his dura is calcified, not only OPLL. So and then did this, put a lumbar drain, and patients do well. But I would agree with Alfredo. If it's not focal OPLL, it's extensive, I would go posterior every single time.
Did you know the theory, the concept of the floating island that time, Nader?
I did not, and I don't know. I mean, it's you know, it's compelling. There's good pre and post op imaging that's published. This is a case that's over 10 years old. So, but yeah, I would, you know, I would go posteriorly, not necessarily just leave the floating island. And I think it'll be fine. But my issue with it is, you know, you want to put a cage, right? And I don't know how, you know, you don't want to put that cage and push that floating island onto the onto the cord. But yeah, I'm aware of the technique. Do you use it, Alex?
Well, it is still, you have to be able to swim if you do the concept of floating island. So I go 100% for posterior. I love to hear this concept, and I leave it to my neurosurgeon colleagues, but I don't want to risk to run into a problem with CSF. I can't swim the way you are able to swim, Nader.
Yeah, I see. We see how this is resected here. See, that's yeah. But yeah, if you put a lumbar drain, and if you put, like, I just put gel foam actually, and then put the cage, and then sprayed Tecile after I put the cage in. I didn't put the Tecile and then they push the cage in, because you run the risk of pushing the Tecile onto the cord. So what I do is just a small piece of dura repair or even gel foam sheet. Then you put the cage, then you put the Tecile. But if you drain the patient, give them 5-7 days lumbar drainage, it shouldn't be a problem. It should not. So this is a patient who presented with neck pain and quadriparesis. What would you guys do for this? First of all, is that a patient that can be randomized?
Nope.
Okay.
I think I would go anterior first, and then anterior first to get a better alignment, and then if needed, posterior decompression, maybe 3, 4, 4, 5, 5, 6, and wait and see, MRI control, and if there's some compression needed, posterior.
Good. Yeah, I thought the same. She's so I thought this is pretty fixed. She does not really reduce. I mean, some reduction when she's lying supine, obviously. So I usually address these with a front back. You can get away with the front, but this lady had osteoporosis. T-score was about minus 3.5. Cachectic. We put a PEG tube first, gave her nutrition, and then did the surgery. Then she was weaned off of the PEG tube over weeks. BMI was 14 before we did the case. We got it up to 17, and then we did it. This is a post-laminectomy kyphosis patient too. So fixed cervical kyphosis, 360. And this is an older patient. He's 80. And what we did is a posterior decompression fusion, only for a year later for him to show up with an adjacent segment disease extended into the occiput. So that's all I have, guys. Thanks for including me. And I don't know who's presenting next week.
I don't know. I have to look. Nader, may I ask you, when you do a front back, the case, the first case, it was like a 3-level, 4-level, one before, yeah, 3-level ACDF with plate. What is your decision when the patient cannot recline, when the patient has to be in this kyphosis and he has got Lermitz sign, is bad? What is your approach then? Would you just say, okay, I'm quick, I do it anyway, with hyperextension, although the patient is getting worse with hyperextension?
Yeah, that's a great question. You're always worried about, like, if you're extending the patient, those ligaments posterior will buckle in. I don't have, for this patient, so what you do is, because you're going from the front, you get your baseline signals, okay? And you see your comfort level. And as long as the signals don't change, I'm comfortable keeping them. But obviously, if there's a change in signal, you need to do something different. You need to keep them maybe a little bit in more neutral position. And then as you're removing the disc, you can extend them a little bit. I find, though, rarely that, hyperextension, like not hyperextension, like extension, rarely would cause an issue, because you're extending and you're distracting, so you're stretching. And I find that when you go anterior, it's pretty safer than when you're going posterior in patient with severe cervical stenosis. Oftentimes you get your signals anteriorly, and then you're flipping the patient for a posterior approach. So let's say the patient has OPLL, okay, and you get signals, and you put the patient in a 3-point pin Mayfield hedges, and then we flip them, and now the signals have changed. I find that more common than a change in signal in patients with deemed for an anterior approach, or an anterior than a posterior approach. But certainly I usually use neural monitoring. If I get baseline signals, I stick with them. If they change, I need to do something about it. I need to change their head position.
Oh, thank you.
I got a question, Nader. How much value you give to the C1 slope in the post-op X-rays? Because my post-op X-rays look exactly like that. It's pretty good. It's pretty decompressed. But what I see in my post-ops is like C1, C2 is hyperextended. It's like compensating something, and there's some neck pain residual, and what Ed Benzel told me once, if you put that C1 slope parallel to the floor, it's good. No matter what, in the cervical spine is good. If it's pointing downward, something is going bad, and you need compensation above or below that, and that's the main trigger for complications, PJK or DJK. We don't see much PJK in C1, C2, but something's happening in C1, C2 facet joints. It's pretty novel facet. So, but if you look at the post-ops, it typically looks like that. Like C1, C2 is looking downward.
Yeah, I mean,
What's
that's
your
what
thoughts
happened to
about
this
it?
guy. I agree with that. I mean, you make an effort to keep it horizontal as much as you can, but no matter what, especially with posterior approaches, you will lose lordosis. You know, for this guy, see, pre-op he looks like this, post-op it's worse, like in terms of alignment. And no matter how you crank it, the T1 slope increases, and the C2 angle here, end plate, is kyphotic. And that, I agree, that drives adjacent segment disease, especially on this guy. So see how it was? And then now this is the result because of the joint overcompensating. Then you got a pannus and then a dorsal ligamentous flavum. I mean, you got to make an effort to give the patient the best alignment possible, but sometimes you can't. I mean, I don't know. Do you have any thoughts about it yourself, Alfredo? What, you know, we'll make an effort.
I think it's mostly on the position in the OR. We typically use Mayfield or Gardner Wills or whatever, and we look at the subaxial cervical spine and how it corrects the kyphosis or whatever. But we don't look at the compensation. We learn how to do that in the lumbar spine. We need to do lordosis in this place and in this place to reduce the pelvic tilt compensation. And I think it's pretty much the same in the cervical spine, but the pelvic tilt it's above, it's not below. It's in the C1, C2, not in the C7, T1. So I take a lot of more attention on how C2 looks in the intra-op, and I take some effort to, if I can put pre-straight to the floor, pre-parallel to the floor, to put a laminar screw in C2 and do some cantilever with that rod to C7 to get C2 in a better position.
Yeah, I agree. I mean, it's driven by a higher T1 slope. I agree with that. So yeah, you got to pay attention to this. So that's what Dr. Gilroy is saying, Alfredo is saying, like you got to make this horizontal but with positioning. An issue usually with posterior approaches. So you got to, crank the patient up, lift, distract and pull them up a little bit. So you won't fuse them. You won't increase their T1 slope and hence the C2 angle. Good.
Yeah. Nader, did you or can you tell us a percentage adding osteotomy in these situations? I don't like it. This is too dangerous for me. I'm not a guy who loves the osteotomies in the C-spine in this setting of myelopathy because patients improve anyway from decompression. So when I ask the patients, are you happy with the surgery? Mostly they say yes, because the symptoms get better, the gait is getting better. And then I look at the X-ray and I think, oh, so I could have added an osteotomy. Is this overtreatment? Do you think it's we should do this? What is your percentage? Because mine is honestly 0 in the last 5 years.
Yeah, I don't do it. But however, though, you pay attention to the alignment. Let's say if someone has a fixed cervical kyphosis, your surgical planning should include probably a front-back operation. I think gaining cervical lordosis through a posterior approach, gaining cervical lordosis is very difficult. Preserving it's not easy, but you should aim towards it. But adding cervical lordosis with an osteotomy, given a patient with severe myelopathy to start with, that's a lot of surgery, right? Like you're doing two things. You're doing cervical myelopathy surgery and deformity surgery. So I usually, try to be cognizant about the alignment preoperatively by choosing the approaches. But if I choose a posterior approach, I'm accepting some loss of cervical lordosis, unfortunately, and I won't expose a patient to an osteotomy. It's too much surgery, high risk surgery to start with. The cord is sick, like you have severe stenosis. You want to add another factor that may drive a neurological deficit like an osteotomy? I'm not sure about that. No. Now, if someone has an issue with alignment and you want to, because of cervical kyphosis, but there's no significant stenosis, sure, then it's a deformity surgery. But I'm not sure how many do that unless the patient has a chin on chest deformity. Like if someone has it's a little bit forward and has severe neck pain and no myelopathy, no radiculopathy, it's a hard sell to say, okay, when I expose this patient to multi-level osteotomies or like a C7, T1 osteotomy, 3-column, just for neck pain, and the neck pain may not get better. I would do it for significant disability, like loss of horizontal vision or like dysphagia, not just neck pain.
Nader, do you use 3.5 or 4.0 diameters for the rods? Do you use thicker rods in the last couple of years?
I've used everything. I've used 3.5 to 5.5, like 3.5 in the cervical spine to 5.5 in the thoracic. I've used 3.5 everywhere, and I've used 4.0. On average, 3.5. That's what I do. Like most of the time, like not not on average, like most of the time, 80%. But I've used the transitional rod a lot, and I've used the 4.0 rod a lot because the screw head will accommodate both a 4.0 and a 3.5 rod.
Nader, may I ask you a last question? When the radiology report documents there is cervical stenosis, do you agree in a high percentage, or do you have your own diagnosis of cervical stenosis? Because for me, I often see no stenosis where the radiologist says it's a compression of the myelin. Maybe it's a national issue here in Switzerland, but I see an overdiagnosis from the radiologists and an underdiagnosis from the symptoms.
I agree. I usually the report is a little bit worse than the image, in my opinion. Most of the time, it's like, to me, it's if it says moderate, then it's mild. If it says severe, it's moderate. If it's it's a little step. Like my interpretation will be it's a little step less. But yeah, I agree with you. I hope as Wendy tuning into this, I not know all the time. I agree with the report. They say severe stenosis. I look at it, it's like not that severe. It's maybe moderate. I agree with you, Alex, on this.
It's a gap there for artificial intelligence.
Exactly, but when it's helpful when, for instance, you really like for a foraminal stenosis where you really know that, okay, this guy has a C6 radiculopathy due to severe foraminal stenosis at C5, C6. I appreciate the radiologist saying that there is severe stenosis so we can get it through insurance. Because if they're like, if they're not, if they say it's mild and it's severe, then or if it's moderate and they say it's mild and the patient's symptomatic, then that's difficult too, because insurance companies won't look at the scan; they will look at the report.
Yeah. So Nader, Dr. Mike Selby just mentioned that he will host next week Dr. Dugal. It's about cervical total disc replacements, and I think it's still the cervical spine like this week. And thank you very much for giving us this supreme overview about cervical myelopathy, what is evidence-based and how to implement it in your daily practice. Thank you so much, Nader.
Thank you, everybody. Thank you, Alfredo. Thank you, Alex. Thanks Mike. Sorry the thing was not unmuted. And looking forward to seeing you next week, guys. Have a good evening or good morning, wherever you are.
Thanks. Great.
See you. Bye.